Chapter 26, Concurrent Disorders During Pregnancy. A pregnant woman who has diabetes mellitus is considered a high-risk pregnancy since many complications could occur. During early pregnancy, which is from gestational weeks 1 to 20, the maternal metabolic rate does not change much, but release of insulin can increase, causing her to become hypoglycemic. During late pregnancy, gestational weeks 20 to 40, levels of the placental hormones increase due to the rapid growth of the fetus. These hormones can cause resistance to insulin in maternal cells to provide an abundant supply of glucose for the fetus. This can cause her to not have enough insulin, and she can have periods of hyperglycemia. Maternal effects for a woman with pre-existing DM includes a greater risk for preeclampsia, ketoacidosis, UTIs, hydramnios, larger fetus, which can make for a difficult labor, or shoulder dystocia, which is where the shoulders get stuck at the birth canal and is a medical emergency. The fetal effects really is determined on how well blood glucose levels are maintained to reduce the vascular impairments. Congenital malformations include neural tube defects and cardiac defects. Fetal size is one effect. Infants born to diabetic moms can have macrosomia, which is a large fetal size, which is greater or equal to 4,000 grams. Neonatal effects that can occur are hypoglycemia, hypocalcemia, hyperbilirubinemia, and respiratory distress syndrome. All of these risks can be reduced if the maternal blood glucose levels are stable during pregnancy. A detailed history needs to be obtained. How long has she been diabetic? How well is her blood sugar controlled? And any other medical problems. Does she have good support? Does she have any learning needs? A physical assessment is needed as well. Blood pressure needs to be monitored and documented as she is at risk for preeclampsia. Labs will be obtained. Getting a baseline for kidney function is a good idea. Doing a UA to monitor for ketones or signs of a UTI. If she hasn't had a recent A1C, then one should be obtained. Fetal surveillance may be more frequent since there's a greater risk for congenital anomalies. She will receive the same screenings as a patient without diabetes. During the third trimester, closer surveillance of the fetus will occur. She may have additional ultrasounds, may need biophysical profiles. Many will start doing twice-a-week non-stress tests during this period as well. Close monitoring for growth restriction of the fetus is needed. Therapeutic management includes to normalize and maintain the maternal blood glucose level that are as close to normal as possible. We also want to help increase the likelihood of having a healthy baby and avoid accelerated impairment of maternal blood vessels and other major organs. She should meet with a dietitian or diabetic educator to help with nutritional needs. Ideally, it would be beneficial for the woman to have preconception care before becoming pregnant to determine good glucose control to decrease those risks to the infant. She will also do self-blood glucose monitoring as directed throughout her pregnancy. She needs to stay compliant with her insulin regime. Doses of insulin may need to be adjusted throughout the pregnancy. During the first trimester, insulin needs generally decline. The woman can experience episodes of that hypoglycemia. During the second and third trimesters, the need for insulin will increase as the fetus grows and mom needs more calories. During labor, they strive to keep her glucose levels as close to normal as possible to decrease the chance of hypoglycemia for the infant. Insulin needs will typically fall quickly after delivery. Gestational diabetes, GDM, is diabetes that occurs during pregnancy. The risk factors for gestational diabetes include overweight or obesity, over the age of 25, previous birth outcomes often associated with gestational diabetes, which include macrosomia, maternal hypertension, infant with an unexplained congenital anomaly. Gestational diabetes in a previous pregnancy, history of abnormal glucose tolerance test, if they have a history of diabetes in a first-degree relative. Diagnosis is done by screening for gestational diabetes. All women should be screened between 24 and 28 weeks by doing glucose challenge test known as GCT. The woman is given 50 grams of oral glucose solution. 1 hour later, they take a blood sample, and if it's over 140 milligrams per deciliter, A 3-hour oral glucose tolerance test is recommended. In the oral glucose tolerance test, known as OGTT, the woman ingests 100 grams of oral glucose solution, and glucose levels are determined at 1, 2, and 3 hours. Diagnosis is made if the fasting sugar is greater than 95, 1 hour greater than 180, 2 hour greater than 155, and 3 hour greater than 140. The maternal, fetal, and neonatal effects are similar to those with pre-existing diabetes mellitus. Since GGM develops after the first trimester, which is critical for organ development, it is not associated with an increased incidence of major congenital abnormalities. Therapeutic management should include a referral to the dietitian or diabetes educator or help with dietary changes. The provider should discuss the benefits of exercise to help control blood glucose levels, should be taught how to do self-monitoring blood glucose levels. Typically, daily, they will check fasting and 2-hour postprandial. Fetal surveillance includes twice weekly NSTs, around 28 weeks for poor glucose control, and by 34 weeks for someone who has well-controlled glucose levels. Nursing considerations include helping the woman achieve good glucose control. To do this, you must assess how well she understands the treatment plan. You must assess her knowledge level to adapt your teaching to that, assessing if she has correct technique with self-glucose monitoring and insulin injections. Your goals need to be focused on an area you want her to learn. Your interventions can't be just teach. Teaching is important, but you also have to determine, is she comprehending and can she demonstrate to you? There are so many topics that need to be taught to a gestational diabetic. Remember not to bombard all at once and to provide written materials to reinforce the knowledge. Iron deficiency anemia causes 75% of all anemias during pregnancy. It's very hard for all the iron requirements to be met in the diet alone. Primary sources include meat, fish, chicken, green leafy vegetables. The maternal effects are often minimal, but include pallor, fatigue, lethargy, and headache. Some women will experience pica, where they crave non-food items. The fetus will usually take all the required iron it needs from mom. If there's poor iron store at birth, then anemia can continue until that first year of life. Therapeutic management includes prenatal vitamins, which contain iron, and iron supplements may be prescribed as well. They will prescribe ferrous sulfate, 325 milligrams, 1 to 3 times a day. This should be taken with vitamin C to help with absorption and not given with calcium. Many times the iron supplements are continued for 6 months after delivery. Certain infections during pregnancy can be harmful to mom and or a baby. Viral infections are typically mild to an adult, but to a fetus they can cause many problems. Cytomegalovirus is a member of the herpes group. A primary infection is most dangerous to the fetus if the pregnant woman contracts it while pregnant. Possible problems to the newborn is an enlarged spleen and liver, CNS abnormalities, and growth restriction. CMV is a leading cause of hearing loss in children. Rubella is caused by a virus transmitted by droplets or through direct contact with an article contaminated with nasopharyngeal secretions. The virus crosses the placental barrier and can infect the fetus. The greater risk is during the first trimester when the fetal organs are developing. If infected during the first trimester, 90% will have congenital rubella syndrome. This includes hearing loss, intellectual disability, cardiac defects, growth restriction, and microcephaly, which is a small head. Therapeutic management by preventing exposure, educating women to stay away from anyone who could have rubella, and also telling her not to get pregnant within 28 days after receiving the vaccine, as it is a live virus and the fetus can be exposed to small amounts of the virus. Genital herpes is one of the most common sexually transmitted diseases. The biggest issue is neonatal herpes infection that is passed on at time of delivery. This can have local infection of the skin, eyes, or mouth. If mom has active genital lesions, a C-section should be scheduled. Non-viral infections can occur as well during pregnancy. Toxoplasmosis is a protozoal infection that can be transmitted through raw or undercooked meats, through contact with infected cat feces, or across the placental barrier. Fetal effects depend on when the infection is transmitted. Severe fetal complications can occur if it's transmitted in the first trimester. The complications include hydrocephaly, which is water around the brain, microcephaly, small head, and calcifications within the cranium. Group B streptococcus is known as GBS. This gram-positive bacteria colonizes in the rectum, vagina, cervix, and urethra of the pregnant woman. Transmission to the neonate is very serious and can result in death of the neonate. Early onset of the infection for the infant would occur typically within 48 hours of birth. Sepsis, pneumonia, and meningitis are the common diseases the infant can develop when exposed. At about 35 weeks gestation, the provider will do a vaginal rectal swab to test for GBS. If the swab is positive, the woman will receive antibiotics during labor to decrease the risk of the infection to be passed on to the infant. If mom is GBS positive, the drug of choice for her to receive is penicillin if she's not allergic. If so, ampicillin, cefazolin, clindamycin, or erythromycin can be given.